So, good morning, everyone. First of all, thank you for inviting me. It's a real pleasure because coming back to 2008, our department in Italy was the very first one in Italy with a DTS equipment. So we have a very strong connection with the DTS. And my degree thesis, the topic was chest digital tomosynthesis. So I'm very connected with this technique. So, as Matthias said before, chest X-ray is the most common imaging modalities for known or suspected chest diseases. And the goal of the chest radiography examination are to help in identifying or exclude diseases processes that may involve the thorax. Sometimes it's helpful in determining the etiology, symptoms, and potentially follow its course. So we have to focus on etiology and the course of diseases. And chest radiography, it's very useful, in evaluation of the lung parenchyma, airways, mediastinum, pleura, and thoracic cage. However, that's a problem. Chest X-ray sometimes is not infrequent to identify equivocal findings or miss some lesions. So that's the point. We have a very common imaging technique, very useful, low cost, very informative examination. However, sometimes we are not able to recognize diseases. And that's the reason why sometimes extra projection or CT scan has to be done to solve doubtful or equivocal cases. And that's why the poor conspicuity of a lesion or for the overlapping, as Neria showed us before. So the aim of my presentation is just to give some concept about DTS and maybe clarify in which kind of patients we may obtain more information, so the clinical possible application of chest DTS, and so why we have to use it if we have it. In all of this area of our chest. So DTS is a simultomographic technique. So my colleagues at the very beginning are, I say, scared about DTS because they say, oh, it's like the old tomography. It's not like the old tomography. It's quite different because we have the patient, we have a flat panel detector, we have the movement of the X-ray tube and so on. And then we have the volume. A volume of our patient. So it's a simultomographic technique. Sometimes we may experience some kind of artifacts, like the blurring artifacts because of respiratory motions. So we have that the patient has to keep 12 seconds apnea for the chest DTS. And so a very old patient that can't take his breath, it's not our patient. So if you have a very old patient with distress respiratory symptoms, DTS is not a good option for these patients. So we have to select to obtain the best results from DTS. Very interesting, we can perform upstanding and supine position, so we don't have any kind of problem regarding the status of the patient if the patient can't stand the upright position, so we can perform DTS and supine. Then, by shift and adding all the projection, we can obtain a specific plane, and that planes are reconstructed by the entire volume of the patient. So, which can be the possible clinical application in chest diseases? I think that one of the main problems is related lesions in recognizing, and in particular, if we have to distinguish true lesions from pseudo lesions, because we know that the main problem in chest CT is distinguish these two aspects. So I want to an interactive session. So Anyone can tell me something about this chest X-ray? Anything wrong? Is normal? Pardon? Okay. No, doesn't work, okay. So scoliosis. Any consolidation? Neria is laughing because she knows. Maybe there is a nodule. One, two, three, four, five. Okay. That's very interesting. That's the same we noticed on this chest X-ray. So, in this old patient, are you sure that this is a nodule or just a bone island? We don't know. So, we perform digital tomosynthesis. Let me show you just some planes, not the entire volume, but I select some planes. So moving from the anterior to posterior part of the chest. That's a nodule. Then we perform for staging chest CT scan. So quite useful in distinguish lung nodules. What about this patient? As you can see, our population is quite old. Okay, so in Trieste we have the oldest people in Italy. So we are facing this kind of problems daily. So is true lesion or is just because of dysmorphic bones or something like that? Anyone can see anything? Okay. That's perfect. I think you mean this. Correct. We can perform DTS. Why not? And that's a true lung nodules. Please compare chest X-ray with DTS and CT scan. How easy is to recognize this nodule on DTS? What about this? More findings. I agree with you. So there's something pathological, or I think these three nodules all of these nodules. Can you distinguish if these nodules are pleural nodules or parenchymal nodules?
From the parenchyma, not from the pleura. I think these are from the parenchyma, from the lung parenchyma, I think.
Okay, so I partially disagree with you.
Okay.
Because we are quite familiar with exposure to asbestos. So we assume that those kind of alteration are related to previous asbestos exposures. Okay, but we don't know if just beneath this pleural plaque there is something else. So this is one selected plane from DTS, and as you can see, that just beneath the costal wall, the thoracic cage, we see all of this calcified pleural plaque, as you can see here on axial CT scan. But no nodules were found on chest digital tomosynthesis, so it can be quite useful even for those cases. And what about this? Is everything okay? Or maybe something?
There's a fracture there, I don't know.
A fracture. Well?
Upper right side.
Upper right side. Okay, anyone else? Any other idea or comment?
Oh, and maybe there is a low density nodule on the left, on the right.
So you mean
to
this
the
one?
bases. No.
Here?
To the base. No. Here. There.
Here?
There. Yes.
Old people, just calcified cartilage, this one.
Okay.
Okay. So my attention was here. Just compare the right to the left portion, the middle area of the lung. Do you think that this one is the same opacity, the same transparency, or is there anything different here? Yes, I know, I'm just taking a lot of time, is okay? Okay, so we can discuss here cases. Okay, thank you. Just stop me, okay? Yes, there are different. My attention was about here because I see a smooth opacity, but I can't distinguish or say anything else. So we perform DTS. This is one of my favorite cases because take a look at this. This is not a rib fractures, but this is a dysmorphism of the thoracic cage. We call it bifid ribs, okay? But this kind of alteration can simulate an opacity. Maybe this patient has some cough. Oh, we see a consolidation, and we maybe clinician gets antibiotics, but this patient doesn't need antibiotics because this patient don't have any kind of consolidation. That's the point. Oh, another one. This one is maybe my favorite case of all time. There are nodules, bilateral nodules, but it's very hard to say if these nodules belongs to parenchyma or not. So we can notice bilateral nodules, but we always have to know something about anamnesis of the patient, so we have to know the clinics and other. Let me show you what happens during tomosynthesis. So this one is the very anterior images of our thorax. So this is skin and going in the posterior part of our chest. This one is a normal chest DTS, as we can see in PACS system in our screen. Just scrolling images, 50 or 60 images, and so we move in the posterior part of our chest, and all of this opacity were due to skin nodules because this patient has a neurofibromatosis. Okay, impossible to say on chest X-ray, but not for you. Yes, if you see the patient, that's the point. If you see the patient, you can assume that those are, in fact, in this particular case, one of my favorite techs told me, Elisa, there's something wrong with this patient, come and see him. So I can see all of nevus.
That's what, sorry that I interrupt you, that's what I say to the radiographer. Show me, draw me what he has on his skin.
Yes.
For the X-ray of the chest and for the mammography as well. I need to know what she or he has on the skin and draw to know.
Yes. It's fundamental. It's absolutely important in the interaction between the technical part for the medical report. Oh, so. And what about this? It's quite similar to the other one. Anything pathological? Again, nodules. Yes, I love nodules. So, 1, 2, 3 more. One on the right side, one in the left one. Yes, you mean this one and this one. You can tell me something else or something more specific about these nodules? Anyone?
You only have this.
Yes. Maybe there are more nodules. So you can tell me if this one is, or this one is, belongs to parenchyma, or this one belongs to parenchyma. That's the point. Sometimes we can't, from this we can't say that. So we perform digital tomosynthesis and take a look at this. This one is a true lung nodule, while this one is a bone island. It's not easy to distinguish, to discriminate the correct location of nodules, and that's in this patient. I think that DTS can be very useful. So, as I demonstrate, digital tomosynthesis offers a high level of sensitivity for nodule detection by minimizing the anatomical overlap or condition which mimic pathology. But there are some specific cases in which I do love DTS, because as you can see here, it can be very hard to recognize nodules or lesions in specific area of the chest, which are called hidden areas. Very difficult, so in the apex, in the paradiaphragmatic areas, or mediastinum. In particular in oncologic patient. So we explore these two different aspects and topic. So one of our research was aimed to assess the clinical impact of chest DTS in the management of the oncological patient with suspected pulmonary lesion on chest X-ray, both as a first examination or during the follow-up. And what we found that we reduce of the half the need of perform CT scan after the implementation of DTS in the workflow of these patients. So let me show you some examples. Female, age 72, pre-operative X-ray for melanoma. We do not have comparative previous images. Is there anything that you can highlight? Again, nodule. Of course. Ça va sans dire. Lung nodule, suspected lung nodule. Where? In the right apex. Yes, I agree with you. However, it's a bone island. No need to perform a CT scan. Interesting. So we gave a score of 1, so definitely benign lesions. What about this? Female, 59 years old, heavy smoker, previous colon cancer, and we do not have any comparative previous image. anything. Mhm.
Is
Mhm.
large, and she has emphysema.
Okay.
I don't know what happens on the left pleuroddiaphragmatic.
Okay. I like what you say.
Yeah.
Okay, so I have some doubt here because I see an opacity. I don't know if what this is, this transparency. So we decided to perform a DTS. However, this patient wasn't able to keep an adequate inspiratory apnea. So, as you can see, it's quite blurring. We are not able to distinguish the age of all of our structures. So, we wasn't confident regarding these findings. So, we perform a CT scan and was a gastric hernia. So, sometimes we have to perform to clarify a CT scan to clarify our doubt. We wasn't able to do that because of the clinical status of the patient. Yeah, we wasn't able to. No, because this one was acquired in the supine position. Okay. Female, 63 years old, preoperatory XA for breast cancer. So, nodules, okay. Where? Right side, correct. So, we was pretty sure that on DTS, this one is a DTS image, that this nodus belongs to parenchyma. So, first stage, we perform a CT scan and we confirm this alteration. Take a look at this. Two different patients. I called this topic similar findings but different results. Why? Because take a look at this and this. I was lucky enough that this opacity was in the same right of the patient. So we have a smooth opacity, middle area of the lung. So we decided to perform a DTS and take a look at this. This one, opacity, score 4, lung nodule, while lung opacity, thoracic cage dysmorphism, score 1. So similar findings but different results. And what about this? Two different patients. Is there anything wrong with them? I guess yes, but what? Where? Down. Yes, in the paramediastinical areas. Here we have an increase in opacity in both patients, here and here. So what we can do now, we always have to perform a DTS and take a look at this. How can we call this? Not different in glossary of terms. So this one is a lung nodule, okay? Score 5, we are pretty sure this one is a lesion. And what about the other patient? This one is a bone island. So score 1, no further examination was requested. So in our series of patients, almost the half of these patients were solved by DTS, while 56% required a CT scan, sometimes to confirm lesion, others to stage. Let's move to the hidden areas, which is a very interesting topic because those areas, so the apex, the hilar region, the retrocardiac region, the peridiaphragmatic region, are very difficult to examine on chest X-ray. And so we want to evaluate the capability of digital tomosynthesis to characterize a suspected pulmonary lesion in the so-called hidden areas. So I previously showed this case. So we have here in the paramediasthenic area an opacity which belongs to a bone island. So score 1, we do not have any kind of doubt regarding this opacity. But what about this patient? Any idea? Is everything normal? Hmm? No, please. Sorry? Right apex. So you mean here? Hmm? On the left eye. It's quite symmetric. Take a look at this. Symmetric alteration is just because of the ossification of the cartilage. But I hire you. So yes, the right hilum, it's more dense. We can see an opacity of the right hilum. Take a look at this. So nice, it's a nodule which was confirmed by CT scan. It's a very difficult case, this one. Yes, I know. And what about this? Our old patient with calcified cartilage, chondrosternal cartilage. But is there anything wrong with it? Maybe again the hilum. The upper, okay, so we perform DTS. What we can notice here, this opacity in the very anterior part of our chest belongs to a calcified pleural plaque. But if you have any doubt, we still follow up those patients. So first, at the very beginning, we scored this patient as definitely benign opacity. However, a few months later, this opacity increased. And so we perform another DTS, which reveal a nodule. And so sometimes can be very difficult to recognize, due to the parallax, nodules just beneath the pleural surface. Yes, you see retiocardiac region. So do you see, can you see anything? Well, my doubt was about this small nodule. So I want to perform a DTS, but as you can see, the patient wasn't able to maintain this apnea, so the quality of the images was not so high. And I still see this opacity, but I wasn't able to discriminate, to say what this opacity were. So we perform a CT scan, and this opacity belongs to calcified, to calcium in the valves, the cardiac valves. Interesting case. Is there anything wrong with this? You have two projections here. Two opacity. So I think here and here. In the middle. Okay. In the here. Okay. Anyone can see anything in the lateral projection? Yes. It's very important, the lateral projection. Here, you mean here. Okay. So we perform DTS, but take a look at what we found. Those one are just a pericardial fat. So not a lesion, but what we can see is this lesion. This was confirmed by CT scan. Yes. We were very lucky. And here in the paradiaphragmatic region, which are very difficult because we know that in the frontal projection we can see about the 75% of the lung parenchyma. So sometimes we need, no, every time that we can, we have to take a lateral projection. But the paradiaphragmatic areas are very challenging. So can you see anything? What about the cardiophrenic angles? The left one. Take a look at here. And maybe something here. So we perform a DTS. Every nodule was confirmed by CT scan for staging. So what we do in our department, digital tomosynthesis is employed as a case-solving examination in patients with doubtful or equivocal findings or chest X-rays. So if we suspect nodules on chest X-ray, we perform a digital tomosynthesis. If it's indeterminate, as I show you, or positive, we perform a CT scan, while if it's negative, we stop. And what's the clinical impact of this workflow? That we reduce enormously the amount of CT scan performed for suspected lesion on chest X-ray. So during the time, the amount of CT scan required was getting down. And as Nerea showed, the radiation dose was a couple of times, so a double a time of a normal chest X-ray in the two projection. And the mean dose, yes, and what about the interpretation time? It's longer, it takes longer in comparison with the chest X-ray, but lower than a CT scan. And the cost of our examination is getting down because we do not perform chest CT in patient who is not required. So, as you can see, the cost of DTS, we do not have contrast media. It doesn't take a nurse to be performed. So we just have the X-ray equipment, the technician, and the medical doctor. That's all. We don't need contrast media, we don't need nurse, so it's very easy to perform. And then we solve our doubt directly. If our techs say, oh, Elisa, come and see. I see something wrong with this patient. Can we perform DTS right now so the patient don't move? We can solve doubt directly on that, in our department, immediately. So, being a tomographic technique, tomosynthesis allows to reduce the anatomical noise from overlying anatomical structures, and this obviously improves the conspicuity of lung lesions and allows a better anatomical localization, has a higher spatial resolution in the coronal plane, and deliver a radiation dose as lower than a standard CT scan, and can be easily implemented after a chest X-ray without full lesion. It's very fast, 12 seconds. However, there are some limitations. The angle of acquisition is limited. Therefore, the overlying structure can be completely removed. And as the exam acquisition requires several seconds and all the acquired imagings are needed, they may be motion artifacts. However, so coming to conclusion, clinicians in our hospital accept DTS as first-line imaging technique to rule out suspected lesion on chest X-ray instead of CT. We can immediate resolution of diagnostic problems directly in the chest X-ray unit. So we can say that digital tomosynthesis represents a problem-solving technique to rule out suspicious pulmonary lesion on oncologic patients with a high pretest probability and avoid the need of a chest CT in about half of oncological patients with suspected pulmonary lesion on chest X-ray. Then, DTS allowed to confirm or exclude the presence of true pulmonary lesion in the so-called hidden areas of the chest, with a slight increase in the interpretation time and effective dose in comparison with chest X-ray. And so, I finish.